Hello, my name is Gui and I'm based in Singapore. It is my privilege first of all to have the opportunity to publish in GUT our recent paper and now the opportunity to present this video about our study. First, I wish to acknowledge the contribution of the key people who helped me to conceptualize this study. The Asian FGID study enrolled patients without an organic disease presenting to GI clinics in these 11 cities across Asia. We recruited a total of 1,805 patients with any and every functional GI disorder. Our study aims were to, if you will, to start from the beginning unencumbered by existing paradigms. We recruited consecutive patients presenting with GI symptoms which could not be ascribed to an organic disease. We applied a 100-item culturally adapted questionnaire based on the Rome Diagnostic Questionnaire. A secondary objective was to compare against existing standards that were largely promulgated from the West. Why identify symptom clusters? As functional disorders, conditions such as IBS and functional dyspepsia are heavily dependent on the description of symptoms to make a clinical diagnosis. Furthermore, it is perceived to be relevant to divide FGIDs into subgroups with putative pathophysiology that could be targeted for treatment. Here I present the 9 symptom clusters that we uncovered. In the columns to the right are the prevalence of the major populations of our study. Moving from top to bottom, I will draw your attention to the clusters with the highest prevalence. First, in F2, we have abdominal pain with diarrhea that was present in 19 to 37% across the different populations. What we found to be especially interesting are the 3 clusters highlighted in black. All 3 represent in some way a combination of upper and lower abdominal symptoms. I have circled the populations with at least 10% prevalence for each of these clusters. You will also note the lack of a distinct dyspepsia cluster. In the next few slides, I will detail the symptoms in the major clusters and propose putative pathophysiology. The symptoms in the most prevalent cluster across all our populations comprised abdominal pain, relief with defecation, and associated with more frequent and looser stools. This closely resembles the original symptoms of the Manning criteria and the latter-day IBS with diarrhea in the Rome classification. You will recall that in our list of 9 symptom clusters, there was a lack of a distinct dyspepsia cluster. So we went back and applied the Rome 3 criteria to our cohort and found that 21% fulfilled FD criteria. However, 83% of these FD subjects had an overlapping diagnosis. So when we look closely at these 3 major clusters, we were able to discern between upper and lower GI symptoms overlapping in these clusters. So in the first cluster, F3, there was epigastric pain affected by eating, which started with a change in number of stools and got better after passing stool or gas. This one we attributed to a gastrocolonic hypersensitivity. F5 was fullness, bloating, bothersome belching, and flatulence, for which we proposed the putative pathophysiology of impaired gas handling. F7 was upper abdominal pain associated with passing less frequent and harder stools. Here, our putative pathophysiology was a transverse colon syndrome. So in summary, our 9 Asian FGID symptom clusters We found many did not conform to the Rome divisions. We found many criteria IBS with diarrhea to be the biggest cluster. We also found that meal-associated symptoms frequently overlapped with bowel symptoms. Looking to the future, we hope that these novel symptom clusters can be applied to investigating putative pathophysiology, testing existing treatments, and developing treatment algorithms for overlapping functional GI disorders. Thank you.